Our next talk is prolonged follow-up, shows continence deterioration after trans-obturator tape, results from a randomized controlled study. Elisabetta Costantini and co-authors.
Well, good morning, chairs and colleagues. This is my disclosure. Well, the retropubic and trans-obturator tension-free medial-urethral sling are considered the gold standard treatments for female stress urinary incontinence. The lack of long-term outcomes is a major debating point in urogynecology, and at present, evidence is still limited in data on the long-term durability of anti-incontinence procedure is a need, and this is particularly true because the life expectancy is lengthening significantly in developed countries in our patients. So this study reports the long-term results with a median follow-up of 8 years of a group of patients who were previously included in a prospective randomized controlled trial designed to compare the safety and the success rate of TVT and TOT in the treatment of female stress urinary incontinence. And here you can see the previous publication in 2007 in the European Urology. This study included 95 patients of 148, and they refers to my university, so my university center, and they underwent a telephone interview in October 2012, and after abstract submission, so in November and in Jan 2013, the patients underwent a clinical follow-up. So we had some data to the abstract. And you can see the previous consort trial, and actually the patients finally included 40 patients in the TVT group and 47 in the TOT group. In the follow-up evaluation, we evaluated the incontinence status. We considered the patient dry or not, and the success was defined as no leakage in any condition, neither stress nor urgency urinary incontinence during clinical and or stress test and or reported by patients. So the inclusion was very strict. And we evaluated the presence of storage symptoms and voiding symptoms, and the questionnaire, the UDI-6 and IQ-7, any further intervention, and the satisfaction scale from 0 to 10, and whether they would repeat surgery. So these are the results. Comparing the long and the medium-term results, you can see that the continence rate after medial-urethral slings tends to decrease in the TOT group rather than in the TVT group. And you can see about 60% in the TOT group and 75% in the TVT one. But there are no significant differences for voiding symptoms or storage symptoms. So in both groups, the post-operative questionnaire score showed a significant improvement. And there were no significant differences between the two procedures for post-operative questionnaire, for the VAS score, and as you can see, 82.2% of the patients in the TOT group and 89.5% in the TVT group would repeat surgery. Just a look to the reinterventions. As you can see in the TOT group, we had set 7 mesh exposure. And this is due to the fact that we use the OP-tape. And as you all know, as our study started in 2002, the only available trans-obturator kit was the OP-tape, which is no longer available because of its high revision rate. In these cases, the patients, after the removal of the mesh, 4 were dry and 3 were wet. So at the end, they didn't change the results of overall results. And we had 4 cases of recurrent urinary incontinence in the TOT group, which was submitted to other kind of anti-incontinence procedure. There are other 2 studies which report similar results. This is the first, which was published in 2012, in which the patients were just a little different from ours because it included patients with stress urinary incontinence and intrinsic sphincter deficiency. And you can see that the risk ratio of repeat surgery in this group of patients was 15 times greater than the TOT group. And in this other study by Halbo, you can see that the objective and subjective success rate for both approaches decreased from 12 to 24 months after surgery, and this decrease reflects a continuing trend of a greater benefit with the retropubic approach. So in conclusion, we can affirm that mid-urethral slings are an effective option for stress urinary incontinence treatment with a high level of satisfaction, and this is true for both groups of patients. And although not significant, probably due to the limited number of patients, this study shows a trend of greater benefit with the retropubic approach. Obviously, not all slings are equal or equivalent, and these findings therefore do not necessarily apply to other trans-obturator approach or retropubic slings. So it's essential, however, to verify that short-term outcomes translate into long-term benefit without added complications. So this is of paramount importance for a correct patient counseling. Thank you.
This paper is open for discussion. What do you think the results, I'll ask a question, without OB-tape, and because I think all your patients had OB-tape, what do you think the results would be using a different tape?
So you mean if you use another tape?
Another obturator tape.
Oh, I don't think that the things could change a lot, in the sense that it's true that this device is actually not on the market, and it's probably different, but it works in the same way. So obviously, in this group of patients, the revision rate was so high and could change something, but not so much in these cases. I think that we should be really careful with our patients, and in the sense that we can have different point of view regards these results. In one sense, we can say that it's true that the continence rate is lower, but it's true too that the patients are satisfied. Why? Probably because in the time, with the aging of the patients, they have other problems which they consider more important. I don't know, as just an idea. Or they feel less comfortable with other problems rather than with incontinence. Or, for example, the urgency, which is a common problem in these women, became more important than an incontinence or a slight stress urinary incontinence. This is one point of view. But the other point of view is that more and more kits are available, and we know that actually the mini slings, for example, my message is to be careful. We have to wait a long time before says that one device is good for our patients.
Okay. I'm Ruud Bosch from Utrecht, the Netherlands. I have a question about the response to your study. In fact, about 2/3 of your original population was included in your long-term follow-up. And it's not exactly clear to me what was the reason for that from your abstract and from your presentation. Is there a risk of bias in the response?
Obviously, it could be. But the problem is that, this was a multi-center study. I asked for the other center to give me all the data, but they were not available. And everyone knows that the follow-up is a problem because only in some centers it's possible to call all the patients and have a clinical examination. This was possible only in my center, so obviously it could be a bias. But at the same time, as the randomization was completely different in the sense that it was central, and if you see the number of patients in the two groups were statistically well balanced. So I think that we can say is that the study has a good, significant statistical results. Obviously, it could be better to have the results of all the participants in the centers. Yeah.
We have time for one more question.
Yes, Michel Jabour, Beirut, Lebanon. Thank you for your presentations. I'm going to raise two questions that may have to do also with the previous session. I'm sure you looked into a little bit why this happened with the TOT and not the TVT. Was it because you didn't do urodynamic before? Were we talking about low closure pressure and very low Valsalva leak point pressure? And then these patients should have undergone a TVT instead of a TOT? I'm sure you looked into that. And my second question is, what would you do for these patients if you really looked into this? I mean, what would be the solution of post-TOT incontinence in your opinion?
Okay, first for the second. As the majority of my patients which need a secondary intervention were in the TOT group, I perform a retropubic approach in these patients. And they are only 4, but they are good results. For the second question. For the first one, it's good questions, I try to stratify my patients to see if there were a difference in the sense that, because all my patients underwent urodynamics and have a complete pre-operative workup. And in our previous studies, we stratified the patients on the basis of VLPP values and maximum urethral closure pressure, and we saw that there was no difference in the two groups and in the results respect these parameters. I try to do the same in this group of patients, but I was not able to find a real answer to this, in the sense that they include patients with low VLPP and low maximum urethral closure pressure in both groups, both in the continent and the incontinent groups. I can give you all my experience in the sense, an impression, that generally I prefer to perform a retropubic approach when the patient had this real severe incontinence with an intrinsic sphincter deficiency associated. So with hypermobile urethra and sphincter deficiency. I prefer the retropubic one. But there is no evidence on this. And if you see in the literature, you can see that there is no evidence not only for me, but for the other one too. And the reason, however, of this decrease of results could be, I don't know, maybe in the fact that something, probably the tape moves in the time. And actually, I am studying two aspects. First of all, by ultrasound to see if in the time, during the years, there is changing in the position which can add some information about the results of incontinence. And the second one, that I think it's important, if there is a time or a break time in which we have the high risk of incontinence. And probably it's true. Probably the risk of incontinence is major in the first year. But I think that it could be a next presentation or next year.
Thank you.